Hello, everyone, all around the world. It is morning where I am, but in many places it is afternoon. So good morning, good afternoon. For those of you where it's evening, good evening. And there are some of you where it's night, so good night. Welcome to the World Society of Pediatric Ophthalmology worldwide webinar on thyroid eye disease. One of the questions that we'll have today is actually, should we be calling it thyroid eye disease? Is it thyroid-related immune orbitopathy? Is it thyroid ophthalmopathy? Is it Graves' ophthalmopathy? And I'm going to be asking all of our speakers as we go throughout today is to let us know in their part of the world what language they use. As I welcome you, let me show you who will be speaking with us today so that you'll be able to see what we see. And that is, we have a worldwide group of experts that are joining us today. We'll be doing their introductions in just a moment, but if we gave you their full introductions, telling you about all of the things that they have done, there would not be time to discuss anything related to thyroid. So we'll give you short introductions, and you'll see a little bit of pictures of them in their home and in the fun life that they lead. We will have audience questions. We want your feedback. This is your webinar. Today, we want you to interact with us. So please list those questions on Facebook and YouTube. We have people on there who will be funneling those questions to us, to the moderators, Jenny, you and I, and we will pass those along to our audience. Additionally, we have questions we'll be asking you. Those questions include questions on menti.com. Mentimeter.com is a place where we can poll our audience. There's your passcode, 45808159. And you go to menti.com in order to be able to see that, or you can scan this QR code and connect. So throughout, we want you to have a second window open where you're able to answer some of these questions. With that, I want to jump right into it and start introducing some of our panelists. First, we have Sao-Wei Leo from Singapore. Sao-Wei is just one of the most bright lights in pediatric ophthalmology. She is energy beyond compare, and one of the very special people involved in the World Society of Pediatric Ophthalmology and Strabismus. And you can see her success on the side here, but her real success is the family. And that's what she wanted to share with you today. We have Mohammed Yunus, my good friend from Lebanon, who has achieved everything possible in pediatric ophthalmology and strabismus, as you can see, including being scientific board members, and he's now part of the American College of Surgeons for the Lebanese section, et cetera, et cetera. I just can't go on forever. And Mohammed, you have to tell me if you're going to golf or ride a bicycle with the whole family there that pushes the cart, but you're a lovely family. Thank you for sharing them with us today. Sylvia is, Sylvia, your picture here with you walking in front of that rock, I just thought this is like the most elegant woman I have ever seen. And I want to be you one day because you just have a style that's beyond what I can actually reach. And I love Sylvia. Went back and got a master's in neuroscience and a master in research ethics, as well as being superstar of strabismus in a country right next to mine in Mexico. And you can see all of her accomplishments next to us with over 430 papers. Her expertise today is going to be invaluable as we go forward. And then I'd like to introduce our person from, as we say in America, across the pond, Tony Vivian. And Tony, I don't know, this is the most elegant picture of the James Bond cool of England I have ever seen. You with a coat that I've been trying to get my wife to let me buy, but she says I can't pull it off, but you do, and you look fabulous. Tony has done everything imaginable in England and across the world, giving of his time, doing global health projects. He has helped lead the workshops that we do to teach strabismus at the World Society, and been a great supporter of ours over the years, and with an incredible family of just warm and caring people. So Tony, thank you for joining us today. And then with that, I will turn the introductions over to my co-moderator from Pittsburgh, Jenny Yu, Jenny, I love the pictures of you all dressed up. It must have been, I'm guessing, during COVID. and with the team of people that you work with, as well as with your adorable and wonderful family. So Jenny, take it from here.
Thank you. Can you advance the slides for me? The next person I'm going to introduce doesn't really need an introduction. David, who is our fierce leader for this webinar and one of the co-executive director for WSPOS, wears many titles and hats. And I would say that probably his favorite ones are that he's a father of 3 and a husband of 1. David Granite, and I'm going to move on to the next one. Next, we have Don Kakawa, who is a oculoplastic surgeon. Many titles here, was the past president of the American Society of Ophthalmic Plastic and Reconstructive Surgery. And you can see his lovely family here as well. Thank you for joining us, Don. And next we have Madhura Tamharkar, who is an associate professor of ophthalmology and neurology and a neuro-ophthalmologist based in the University of Pennsylvania at Philly. And she runs a thyroid eye disease clinic with her oculoplastic colleagues. And I love all the photos of your family here, and love that you guys are taking a venture. And last but not least, we have Rashman Gandhi, who is a neuro-ophthalmologist, trained in both the US and stateside, and currently based in Hyderabad. And with that, I think we're going to get started with Rashman first as our first speaker. Rashman?
Thank you so much. Thank you. I would like to, as I set up my screen, I would like to thank the WSPOS for crafting this beautiful program, and a special thanks to David and Jenny for moderating it and making me part of it. So I'm going to talk about optic nerve evaluation and OCT in thyroid eye disease, and let's get started. So the first thing is optic nerve evaluation, and we are going to talk about the optic nerve function tests.
Rashman, I'm sorry, I'm going to pause for a second. We're not seeing the right screen here in terms of your slides.
Are you able to see it now?
Not yet.
Rashman, you were sharing your web browser and not your PowerPoint.
Got it.
So this is real life from all over the world. So you just have to hit screen share, and when you choose,
yep.
There you go. And then if you can play the slides like you're at a meeting, there you go. Perfect.
All right. So for that. So as I was saying, I'm going to talk about optic nerve evaluation and OCT in thyroid eye disease. Let's get started with optic nerve function tests. What is its role in thyroid eye disease and how does it work? The 4 most important optic nerve function tests are visual acuity, pupillary evaluation, color vision, and visual field assessment. And let's see how does that work in thyroid eye disease. As you know, visual acuity is one of the most important indicators of optic nerve health, both symptom-wise and sign-wise. In most instances with thyroid eye disease, you expect, especially when the optic nerve is compressed, that the visual acuity will be 6.9 or 0.67 Snellen fraction. However, in Ugogo's survey, they found that 12 of 46 eyes had actually normal Snellen's visual acuity. What it tells you is that normal Snellen's visual acuity, you can still have dysthyroid optic neuropathy. The other thing you need to remember when we're talking about visual acuity, that exposure keratopathy, ocular surface anomalies, or retinal anomalies can also be the cause of loss of visual acuity, and that's the reason why the subsequent optic nerve function tests become important. Pupillary evaluation is the most important and the objective optic nerve function test. The swinging flashlight test, I'll pause here and spend some time here, because a lot of times, especially the trainees, make mistake performing the swinging flashlight test. In swinging flashlight test, you actually are comparing one anterior visual pathway against the other. So it's very important to illuminate each visual pathway equally. So it's typically done in dark room. Patient looks at a far object. He should not be looking at you or at your torch, because that will induce miosis because of near reflex. And then the angle of illumination and the duration of illumination for each pupil should be equal. Typically 3 seconds for each pupil and the gap of 3 seconds. Now, once you perform a swinging flashlight test, the presence of RAPD indicates that there is a unilateral optic nerve dysfunction. Typically, when one optic nerve, the fiber loss is 20 to 25%, is where clinically demonstrable RAPD will ensue. However, in thyroid eye disease, around 70% of these patients can have a bilateral disease, can have a bilateral symmetrical optic nerve problem, and those patients, pupillary swinging flashlight test will not demonstrate RAPD. You may have pupils which are less brisk in reaction, but you will not have RAPD. The grading of RAPD with neutral density filter is a good objective way of assessing RAPD, and also it helps in following up the patient in a chronic disease like dysthyroid optic neuropathy. Typically, the neutral density filter comes between 0.3 to 1.2 log units. Another important optic nerve function test would be color vision. I typically use Ishihara's pseudoisochromatic test plate, which is good enough. You have to cut a slack for these patients because they have, again, a tear film anomaly. So you need to have a bright illumination on the book. Patient should be wearing his prescribed glasses if that's the case. And again, the speed. You have to remember that some of these patients, in other optic neuropathies, you look at the speed and how many plates they read. Here, because again, ocular surface anomalies, I would cut a little slack if they are doing it a little slow. And the importance of color vision testing in dysthyroid optic neuropathy was again indicated by UGOGO survey, where only one patient who had optic neuropathy but had a normal color vision. Rest all had some form of color vision anomalies. Move on to the third important optic nerve function test, that's visual fields. The gold standard of visual field testing would be automated perimetry. And as you see here on the chart, more than 70% of all visual field defects you'll find somewhere in the center of the visual field. However, bitemporal defects are also known. Now, typically when patient comes for follow-up or patient does not have an active optic neuropathy, I still end up doing Amsler charting or red desaturation, because that saves time and that gives an early, it picks up a clinically demonstrable early central visual field defect. Other tests like brightness sensitivity, contrast sensitivity, and rarely VEP would have a role to play in these optic nerve assessment in thyroid eye disease. With that, I move on to my second part of the talk, that is, what is the role of OCT in thyroid eye disease? The typical questions are, can OCT help in early detection of an anterior visual pathway disease, number one? Number two, can we prognosticate using OCT as to what's going to happen in this patient? And are there any new signs which are demonstrable on OCT? So there are papers in literature which has said that there are signs, morphological features which are demonstrable on OCT before even onset of clinical disease. And I picked up some of them. These patients do demonstrate thinning of peripapillary retinal nerve fiber layer. Now, this is quite similar to what happens in multiple sclerosis. In multiple sclerosis, even if patient has a subclinical optic neuropathy, you might still find thinning of PRNFL. And there are papers which have suggested that you may find thinning of peripapillary retinal nerve fiber layer even in the absence of clinically demonstrable optic neuropathy. There's a paper by View et al. Published in 2020, which showed that they demonstrated significant thinning of inner retinal layers, and they attributed it to a lower retinal capillary density that they found on OCT angio. They found that there was a lower retinal capillary density both in superficial layer and deep layer. Interestingly, they had divided their patients cohort into 3 groups: patients with clinically demonstrable dysthyroid optic neuropathy, thyroid eye disease but no optic neuropathy, and the controls. What they found is the capillary dropouts was maximum in patients with DAWN, then thyroid eye disease but without DAWN, and then control. So what it tells you is there will be a loss of retinal capillary even in patient who does not have a full-blown optic neuropathy, and also a significant thinning of inner retinal layers. This is a picture which I picked up from the paper, which says on the top here you find a control with a normal retinal thickness, non-DAWN and DAWN. And on the right-hand side, you find that on OCT angio, you find that there is a dropout of the capillary layer, both superficial and deep. What about subclinical? And this is a paper which came from India, from Dr. Kaur from Uttar Pradesh. They had actually excluded, when they were studying the RNFL, they excluded all the patients who had RAPD or any evidence of optic nerve dysfunction. And even in the absence of dysfunction, they found there was a significant RNFL thinning in these patients with otherwise normal optic nerves. What it tells you is that there are changes, morphologic changes, which are going on in the retina and the optic nerve before the demonstrable disease in the clinic. What about prognostication? Around a decade ago, Peter Savino and Helen Danish-Meyer had published a paper, and that was probably one of the early papers which demonstrated a role of OCT as a prognosticating investigative modality. And they found that if the OCT average RNF thickness was more than 60, then patient who underwent removal of pituitary adenoma, they had a reversal of their visual function better. A similar paper was published in Eye in 2018 by Park et al. And they found that if you had a pre-operative RNF thickness of more than 65 micron, then your orbital decompression surgery worked well, and you had a reversal of your visual function, including your visual field effects. What about some of the neuroscience? And this I picked up from IOVS, where they used anti-segment OCT to demonstrate the muscle thickness, which otherwise we use CT scan or ultrasound. And they also demonstrated a submacular increase in choroidal thickness, presumably because of orbital congestion. So in summary, in OCT, you have a prognosis where I think it is fairly mature now to use OCT to prognosticate what's going to happen, especially if you're going to plan orbital decompression. Disease activity and subclinical damage, I don't think we are there yet to say that a preclinical disease, if you get the information, how to use that information and what's the significance of that information. I think much larger study and much more information is required before we go there. So in summary, if you don't know about the preclinical disease, the first part of the talk, that is the optic nerve function test, still remains the gold standard for you to evaluate the dysthyroid optic neuropathy. With that, I thank you for your kind attention.
Wow, that was fabulous. And as Madhura gets ready to give her talk, I have a couple of just quick announcements. We'll have a discussion following both talks. But I want to welcome everyone from around the world. Portugal, I'm reading these from as I'm getting them sent to me. Portugal, India, Chile, Mexico, United States, Lebanon, Israel, Brazil, Argentina, Arabia, Jordan, Saudi Arabia, Sweden, Scotland, Argentina, Honduras, Indonesia, Australia, Spain, France, Germany, Switzerland, Nigeria, Pakistan, South Africa, Canada, Singapore, Hong Kong, and important right now, real time, as we are all here, Sylvia in Mexico is telling us that there is an earthquake that she is dealing with. And we pray to God that she's going to be fine and this won't affect her. And staying with us is the least important thing. You do what you need to do, Sylvia. And we are all praying that this is a false alarm or that everyone will be okay throughout Mexico.
I don't know yet. I am still here and waiting not to lose the internet. So I will check in. Thank you.
All right. Thank you. But don't worry about us. You take care of yourself first, okay?
Yes, so thank you, Dr. Granite and team, for inviting me. I think this is very exciting to see that we have an international audience. Before I proceed, can everyone see my slide? Yes?
Yes.
Okay, I'm going to hope this works. I'm not able to, I was looking at this. There you go. So I do have a financial disclosure. I'm a consultant for Horizon Pharmaceuticals. And I belong to the Penn Neuro-Ophthalmology team. We are a bunch of 6 neuro-ophthalmologists at the University of Pennsylvania, and all of us do different things besides neuro-ophthalmology. For my part, I have a special passion for thyroid eye disease. I run a joint clinic with my oculoplastic colleague, Cesar Briseño, once a month, all day. And it's I can tell you there has never been a more exciting time in this era of thyroid eye disease now that we have new therapies. So what is the objective in the next few minutes? For the worldwide audience, why is this important? How do we diagnose thyroid eye disease? And why do we have to care about what is the staging and the grading? Well, we do have to care now more than any other time. And I'll get into that. By the way, all the pictures that I have in this presentation are of my own patients. We all know what thyroid eye disease is. This audience that's watching worldwide has at least seen one or two patients, if not more. We know that the vast majority of patients have hyperthyroidism, that this disease is more common in women than men, although men can have more severity. It is usually bilateral, very typically asymmetric, and that patients who are euthyroid in the beginning of their eye disease can develop hyperthyroidism anytime within 18 months. This is a great prospective study, a little older study in 2013 in the endocrinology literature that looked at around 350 patients over an 8-year period. And the beauty of the study was it was prospective. And, you know, if you're going to if you're going to answer questions from your patient saying, well, what are my chances of getting thyroid eye disease? You know, it's heartening to know that over 3/4 of the patient, or around 3/4 of the patient, really did not have any ocular involvement within an 8-year period of following them prospectively. 20% developed mild disease, 6% moderate disease, and a very few people developed severe disease. Of course, our patient populations, the ones that we see in the thyroid eye clinic, is a skewed population because those are the patients that are referred to you. 13% develop TED over 18 months. So it's important to know that not everybody will develop thyroid eye disease in the 18 months. There are many, many patients who develop thyroid eye disease, and we know these 5, 10, 15 years after their initial diagnosis. But it's heartening to know that with proper counseling, whether it be smoking cessation, lifestyle moderation, diet, exercise, well, you know, 60%, almost 60% of patients will regress when they have mild thyroid eye disease. And I think this can be very important for your patients to know. These are two of my patients, and I cannot tell you what a big, you know, this is really what sums up the natural history of thyroid eye disease. This is my patient who came to see me many years ago, and she was in the horribly active phase of the disease on the left. And we are going to get into that. And then this is another patient of mine, you know, with one eye pointing north, the other eye pointing south, but who's in the stable cicatricial fibrotic stage of the disease. Both are equally disabling, and both will require different treatments. This is the Rundle's curve, and to this day, you know, prior to the invention of the biologics, we really did not have great therapies to really affect this Rundle's curve. So there is the active phase of the disease that can last from 18 to 24 months. And this is extremely basic. We all know, we have seen patients decades later that will have thyroid eye disease. And then the stable phase of the disease that can go on chronically for the rest of their lives. There are two types of diseases, the fat predominant and the muscle predominant. And the reason, you know, I brought this up is this: we have these beautiful autopsy specimens from a pathologist, Dr. Eagle, who used to work initially at the University of Pennsylvania years ago, and did this beautiful dissection just to highlight on your left is this sort of fat predominant disease where the muscles are a little bit enlarged, not too much. It's mainly fat. And then on your right, you can see these huge muscles. You know, most people would be somewhat in the middle range where they may have a little bit of both. So stages of Graves' disease, I think because this is a worldwide audience, and when I went to medical school, we did not have any other classification but no specs. And I do want to say that this classification did not differentiate between stages of the disease and activity of the disease. It was all sort of lumped in all together. And this classification did a lot of damage in the early onset when we were trying to devise or design studies to look for efficacy of whether it was radiation or some other immunomodulatory agent, that this classification did not differentiate between disease activity and disease grading. And therefore, a lot of the initial studies in the 1990s were flawed because there was no attempt made to really differentiate disease activity with disease grading. So enter the European group of Graves' ophthalmopathy, which for the first time in 2008 put out a consensus statement stating, you know, simplifying the grading of the thyroid disease into 3 forms. And this was such a big change because all the recent trials in the late 2000s and in this decade, in the last decade, were really based off of this UGOGO classification, and I'll walk you through it because that's how you're going to make a diagnosis, and you're going to grade your patients and you're going to stage your patients. So UGOGO simplified the whole classification system into mild, moderate, and severe, and I have pictures to show. So before we get into that, they further devised this sort of clinical activity score, initially published in 2008, a little bit prior to that actually, but really adopted, now very much robustly adopted with the newer classification system, where the clinical activity score, along with the UGOGO classification, helps you to gauge inflammatory activity and to stage the disease. And so these are the 7 criteria. You know, do your patients have retrobulbar pain, pain on up gaze or down gaze, conjunctival injection, eyelid redness, conjunctival chemosis, swelling of the caruncle and plica, swelling of the eyelids. And if you have more than 3 out of the 7, you will stage the patient as having active thyroid eye disease. And this becomes extremely important going forward as you are trying to decide whether your patients require therapy or not. So this is an example of a patient who came to see me many years ago, and she was classified as having mild thyroid eye disease. And as you can see here, she has minor eyelid retraction, mild proptosis, less than 3 millimeters. And how do I know that? Well, because I do ask patients for their license photographs or old pictures, and I can tell you that the vast majority of patients will self-report this. They will tell you, my eyes are bulging. This is not how I looked. Now, in the early stages of hyperthyroidism, if their thyroid levels are higher, they may have eyelid retraction based upon this sort of hyperadrenergic state, which can completely resolve once their thyroid levels normalize. So that's important to know, that just because somebody has eyelid retraction, it doesn't mean it's going to be permanent. These patients may complain of transient diplopia, and almost all of them have dry eyes. So, because this is an international audience, I just wanted to take a moment to talk about racial differences in the normal values of proptosis. And I will say that in our population, when we see patients, they can be Caucasians, African Americans, or Asians, and these are the norms. Overall, these are broad, and I think it's important to know that typically these norms are via Hertel's exophthalmometry. The 12 to 18 millimeters in Caucasians, African Americans up to 24 millimeters could be normal, and in Asians, 16 to 18 millimeters. These are not set in stone. So just because you measured a slightly higher value doesn't exactly mean that they have proptosis. I think the 2 things you want to ask about is, ask your patients, do they feel that their eyes are bulging? Sometimes their eyes may be bulging or may appear to bulge because they have lid retraction and they may appear to be more prominent, or they may really be bulging, or they may have shallow orbits, in which case typically they will not have eyelid retraction. And I think this becomes very, very important, because sometimes you will see patients with no evidence of thyroid eye disease simply sent to you for screening, and that's when I take a baseline photograph. Sometimes you will see patients that will come and say to you, my eyes are bulging, and it's good to take baseline pictures, but it is also good to have patients bring in their old pictures, or maybe have their digital photos on their phones, or even driver's licenses. So, but I think in general, these norms are established based on race. They are not perfect. This is a patient of mine who came to see me a few years ago, and he had all the signs of a moderate thyroid eye disease. So how do you classify somebody as moderate and active? So yes, they have to have lid retraction. He had proptosis over 3 millimeters, and he had constant double vision. Now, the 2 elements that I want you to see here is that he had eyelid edema. It's a little bit different than erythema alone. The eyelid area appears to be swollen, as you can see in this picture. And then this sort of ballooning or cystic appearance of the conjunctiva, which he had, which is conjunctival chemosis, a very, very sensitive sign of active thyroid eye disease. So another example of a patient of mine with moderate thyroid eye disease, As you can see, there is an abduction deficit in the right eye. In the left eye, a great example of hypertrophy of the plica semilunaris and the caruncle, other extremely sensitive sign of active thyroid eye disease based upon the clinical activity score, as well as the conj chemosis that you can see. We all have to know, and as a strabismus specialist myself who does surgeries, this is a patient of mine, and as you can see, that there is a limitation of the clinical activity score, that the clinical activity score does not always reflect the extent of ocular muscle involvement, that we have seen a subset of these patients may continue to have diplopia progression even with low clinical activity score. And this is the perfect example where you look at the patient and say, well, wait a minute, I really don't see a lot of clinical activity, but she really had progressive worsening of the diplopia. As you can see here, the right eye is a bit hypotropic. She's got lid retraction, but really none of the other clinical signs of high activity. And this was shown in a paper in 2016. So, this has been my one area of interest going forward with the biologic therapy is, in these subset of patients that have worsening double vision with little clinical activity score, I still believe they are in the active phase of the disease. And then these are examples of my patients that had moderate.
Madhura, I'm sorry, it's David. I'm sorry. We're almost 5 minutes over on an 8-minute talk. Can you wrap up, please, so we can, thank you.
30 seconds. These are inactive TED. And then, these are patients with compressive optic neuropathy where you can see the compression of the orbital apex. And I will stop there. Thank you very much.
Thank you. And if you can stop sharing your screen, that's terrific. Well, we have a lot of information to talk about. First is Sylvia, are you okay?
Yes, everything is okay. It was a very little far from here in the coast of Pacific and level 6, but we are fine. Thank you.
Yes, a 6 on the Richter scale isn't that little, and thank God you're okay. And we hope everyone else in Mexico is okay. All right, with that, there's so many questions that are starting to come in from all over the world. We have Greece, Uganda, Peru, Albania, Georgia, El Salvador. We have Colombia, Ecuador, Chile, Australia, New Zealand. It just goes on and on. I'm going to wear out if I keep saying where everybody is. But those great talks. The first question I had, and I'd love for everybody to jump in, including Jenny and Don especially, because Rashman, you implied that the decompression, for example, is better if you're watching the OCT. Does that mean that our oculoplastic colleagues should be using that as their guide for when they jump in? Is that what we're looking for?
Well, I would say this, that for me to say that specifically OCT for TED, we don't have enough of data. But if you imply that we use OCT for neuro-ophthalmic conditions, as I said, pituitary adenoma, you do OCT first, and then you are reasonably sure that if the RNFL thickness is not decreased, you know that patient would have a good reversal. And I'm implying, because there's already a paper in eye, that if we do OCT in these patients, you probably would be able to prognosticate.
So, I mean, it almost sounds like if you start to see the OCT change, we shouldn't be waiting for stability. We should be jumping in. Don?
Yeah, no, I just, excellent talk, Rashman. I just have one question / comment. I'm sure like glaucoma, the clinical findings of color deficit, visual field probably lag the OCT. Is that correct? So we should be following something more sensitive.
So it's like this, visual field, even RAPD, you need to have 20 to 25% of the fiber loss before even RAPD shows up, visual field effect shows up. The only problem, like a preperimetric glaucoma, is when you find OCT RNFL thinning, do you jump in and treat, or do you wait? Because I don't think we have a clear guideline there. We know that there are morphological changes which are preceding the clinical signs, but I don't think there is a guideline to say, when do you jump in? Madhura, I mean, do you have any comments?
Yeah, many of these patients with compressive optic neuropathy, and I'm really struggling with 3 patients that I saw this week, is they may have optic nerve swelling because of congestion at the orbital apex from the enlarged extraocular muscles. So it's important to keep in mind that the early stages, you can get nerve swelling. The pallor of the nerve really sets in later. I think, just like with pseudotumor cerebri, where you look at ganglion cell layer thickness and so forth, I think OCT is ancillary. I think it's complementary to your clinical impression. I still think that visual fields, your visual acuity, all of those things are really paramount in making the diagnosis and following these patients, whether it be after decompression or biologics.
So if we're looking at optic nerve function and the retinal nerve fiber layer, do we understand why that's changing? And what I mean by that is, Madhura, you just talked about orbital apex and crowding. We know that the optic nerve is on stretch, it's being pushed forward. We know that the globe itself has a pressure rise from the muscles pushing on it. And when patients look up, the pressure goes up. And at night, we have a Bell's phenomenon when we're looking up, which you know in glaucoma. So what's causing the optic neuropathy? Is it stretching the optic nerve? Is it pressure at the orbital apex? Is it a rise in intraocular pressure, a form of glaucoma? What are we treating, and why if we jump in for decompression, what is it that we're trying to fix?
So I think it's combination of all, and most of the time, especially the compression, you will find it on neuroimaging, because if you know that there are muscle environment, a small number of patients can have an optic neuropathy in the absence of a demonstrable compression on neuroimaging, and that's where you start wondering whether this is a stretch optic neuropathy, if there is an entity like that, or is there because a lot of these people also secrete vasoconstrictor. So is there a vascular insult which is going on simultaneously with the compression? So I think neuroimaging would be, as Madhura said, clinical evaluation neuroimaging is what would be the gold standard.
Yes, and in these patients, Dr. Granite, when you do neuroimaging, in the vast majority, and while increase in intraocular pressure, stretch of the optic nerve, or congestion at the orbital apex with pressure of the optic nerve due to enlarged extraocular muscles, I think the last one where there is enlargement of EOM that compresses the optic nerve at the orbital apex is probably the major driver here in the vast majority of them. Yes, you can have a small percentage, and we've seen patients where there's been a tremendous stretch on the optic nerve, and those are case reports, they're all there. But when I see somebody that comes in with acute loss of vision or loss of vision over weeks, we get an MRI or a CAT scan, and you will see that there is enlargement at the orbital apex, and whether you can give them biologic or decompress them or give them steroids with radiation, whatever the modality that you have at your disposal, the vast majority are because of mechanical compression. With some role with what Rashman said, with pro-inflammatory mediators, whether it's vasoconstriction and so forth.
And can I ask you to, Rashman and Madhura, can I ask you, if you're going to intervene with whatever, whether that's decompression or whether that's drug treatment, how quickly do those changes get better? Do they get better on your OCT? And so can we use that as a measure of how things are improving?
So as Madhura mentioned, a lot of these patients would have a disc edema. So if you're only looking at average RNFL thickness, it actually might be normal, and then or might be slightly elevated. And once you intervene, it'll start reducing. Now the question is whether it is reducing because it is responding to the treatment, or the RNFL loss because the disease process is continuing. And one way to differentiate between the two, at least in other neurophthalmic disorders, would be to look at both RNFL and ganglion cell complex. If you have a normal ganglion cell complex and if you have RNFL which is decreasing, you know that your treatment is working. Now, if both are decreasing, you know that your treatment is not doing anything, patient is on a downhill path.
Yes. But your armamentarium has to be vision, color, and we follow these patients like a hawk. I mean, I literally have teprotumumab production has stopped in the US since January. I have 3 patients I just saw this week. I'm going to see them again next week. I've put them on steroids. They will likely need decompression if they go downhill. But what am I using? Yeah, right? I'm using my vision, my color vision, my visual field, and OCT as an ancillary test. But really, it's the clinical impression is patients coming in and saying, my vision is better. And we have many tools to assess, whether their compression, whether the compressive optic neuropathy is getting worse or better. So I think that from that standpoint, OCT is helpful, but it's not going to ultimately be the only driver of your decision-making process.
I have a question. I'm going to take advantage of our expert neuro-ophthalmologist here. It seems like the optic neuropathy we see in thyroid eye disease is different, meaning that the compression or whatever the vascular insult is better tolerated. You see patients with trauma or acute vascular insult, and that nerve has apoptosis very quickly, but the TED patients with compressive optic neuropathy could go on for several weeks and still you get vision recovery. Do you have any comments about that, or do you find that the same phenomenon that we see?
Don, you brought up such an important point because, for someone like me that is at the forefront of seeing these people, because we have thyroid eye disease clinic and we have a huge referral basis, these patients come in, and one thing I can tell you, I don't have to wake up my oculoplastic colleague in the middle of the night asking them to decompress the patient, right? So you can still get your sleep, Don, and so can Cesar. And I can use steroids, I can use teprotumumab, I can use, in some cases, we've also done orbital radiation if they have a horrendous clinical activity score. But you're right, the mechanism, these patients rarely go blind on you. Like some of the other cases where you have cancer in the back, in the orbital apex, infiltrative optic neuropathies, you do have a window to intervene. And I think that's a good thing. But that just goes to show that we probably is this purely mechanical compression of the optic nerves. And in those patients that respond to steroids, almost, there are people who do, not everybody does, but the ones that respond to steroid, are we just creating a gap between the optic nerve and that enlarged muscle? Maybe that's all that is required, is that little bit of mechanical decompression where the muscle, instead of being 5 millimeters at the orbital apex, is now 4.5 because we gave steroids and they relieve the mechanical pressure. Has always been my thought, because these patients, and when you go back there and decompress the compression, you're not decompressing anteriorly, you're really decompressing at the orbital apex where these muscles squish the optic nerve. So I think that there is some part of this is mechanical. Of course, anatomic, why are some patients more prone for optic neuropathy versus others? I mean, there are studies that have been done on the diameter of the optic canal and so forth, or some people who have a lot of posterior disease.
Great. And then a follow-up question for Rashman. So if you had a patient with nerve fiber loss, for example, and then an optic neuropathy, we see these patients get clinically better. Their visual acuity returns, their field gets better. Do you see a corresponding return of the nerve fiber there?
No, I really don't think that you will find, though there is a study in traumatic optic neuropathy which was done from India, and they demonstrated that there was some return of nerve fiber layer, but I really don't think that the function would return. And I personally feel that there is a threshold. So till that threshold, even if the nerve fiber layer is thinner than the age match control, you still have the function which is preserved. If it goes below that threshold, then the nerve fiber layer is thin, but your function will not return. And according to that paper, I think for TED, it seems to be average RNFL of 65.
Because we are broadcasting around the world, I want to make sure that we touch base for those people who don't have access to OCT and some of the kind of monitoring that we're discussing right now, where patients are coming a long way to get checked and seen. Don Kikau and I started our thyroid center 24 years ago. And we have, hundreds and hundreds of patients we've followed. Not everyone has that, and not everyone has a neuro-ophthalmologist or people who are used to taking care of thyroid-related disease. What do we tell those folks? How should they be following? What's realistic that they can do? And then we've talked about radiation, steroids, decompression as various different treatments. What do they implement?
Madhura?
Yeah, no, thank you. So, you're exactly right. Not everybody has an OCT, and that's okay. We are still ophthalmologists. You can check a patient's vision. You can check their color vision. You can check their visual field. The vast majority of ophthalmology practices should have a visual field machine. You can check for APD. A patient coming in and with thyroid eye disease, almost all of them will come in and say, my vision is blurry, right? So that's your first exam with this patient. Do a good baseline exam. Take baseline photographs. It's easy. It's not that hard. If you don't have a photographer in the institute, take a photograph on your smartphone. There are, and that would be their baseline. I think if people were to ask, well, when do I get an MRI? When do I get a CAT scan? How do I know this person doesn't have a compressive optic neuropathy? How do I know that they are reliable test takers? Those are all real questions. And I think the first thing I would do is your baseline exam is your first screening exam, right? So if the patients come in, they are 20, 25, 20, check their vision, check their color vision, look at their pupils, get a visual field, and take a baseline picture. If they have double vision, that's when imaging comes in. If they have orbitopathy, proptosis, and diplopia, do an imaging study, because why? A, I do want to look at the retrobulbar tissues. B, I want to study the orbital apex. In the vast majority of patients that don't have dysthyroid optic neuropathy, you will be able to analyze their orbital apex on imaging, whether it be a CAT scan or an MRI. You don't even have to give them contrast, just to see if there is any narrowing or compression at the orbital apex, which most of the time radiographically is visible.
Great. We've let this discussion, hang on, Rashmi. We've let the discussion go on for longer than we really planned for. I'm going to give you the last word, but I can tell you that in our center, we always ask people for pictures that predated the Graves' ophthalmopathy, because we don't know what they looked like before. Did they have big eyes? Were they high myopes? And something as simple as that can help you. Rashmi, you get the last word in this section, and then we're going to move on.
Yeah, so the other thing, apart from what Madhura said, I also employ a red desaturation, because it's a very sensitive test of a central red, washing out of the red color in the central field. So a lot of patients who cannot come for follow-up, I tell them at home, keep looking at the target and see color between the two eyes if possible, or between the periphery and the center, is the red color appears washed out.
Okay, we're going to move on and have Sylvia come on to talk about Botox in thyroid eye disease. Sylvia?
Hi, thank you, Jenny and David. I'm going to share my presentation. And to talk about botulinum in this disease, that is a chronic disease, as you can see here, and very important, we have to ask which is the superpower of the botulinum. And it's right, it's a relaxing effect to treat most of the cases, the strabismus, and in this way, the diplopia, the recurrences after surgery, the torticollis, and also you can treat the eyelids, and maybe the effect in the muscle could improve the intraocular pressure. The strabismus is one of the most important signs in this disease, because we could check that you can find some problems of strabismus or limitation or diplopia even before of the tissues, inflammation or something else. And sometimes you are not thinking even in the disease. So this is the problem. This is a chronic and progressive disease in most of the cases. So I want to share with you this work in my hospital when we were deciding what of the doses was right for the muscle, and we studied in rabbits, and we did from very, very low doses until very high doses of botulinum toxin. And we found that it was clear that the response depends on the doses and the changes in the muscle. For example, the fatty connective infiltration, the fibrosis, the phagocytosis, the degeneration of the muscle depends on clearly the doses, the higher doses. So I want to keep this in mind, because I will show you. For example, you can look very clear the doses, the low doses, the muscle is not so bad. And then with 20 units, and then with 50 units, you can see here the fatty infiltration and the complete degeneration here in sarcoplasm and the problems in the degeneration muscle. So when you are starting the doses, you're going to have all these changes very well known: reduction of contraction, the mitochondrial changes, the fragmentation of the sarcoplasm, endomysium, perimysium, and the filtration of the fat and connective tissue. In the second month, you can see the effect of the treatment because you're going to see the reduction of the strabismus. But what happened then? So in some cases, the patient recover the effect because you know that some new contacts is going to liberate acetylcholine. And then is the moment that you can add more toxin here. And finally, in the month 5 or 6, you're deciding the new doses maybe. So the idea is to add more toxin here in the middle of the way in your treatment. Obviously, keep in mind to start with a higher doses than normal, because a higher dose, you are going to get a greater degeneration because you're going to block more neuromuscular terminals. And you can decide a higher doses when you have chronic evolution, big strabismus, or you're going to do a reinjection, or you had a bad first response in your initial doses, or because you have a fibrous condition. And think about adding toxin in the middle of the way, depends on the response. And adding doses is much better than inject only the first time, because reinforce the blocking effect of terminals on way to recovery, increases the muscle degeneration. And in this way, you have to try to preserve the muscle weakness more time. In this case, in thyroid strabismus, the best effect is in the inflammatory phase, and a higher doses of botulinum maintains a less contracted muscle. And also we can try recurrent strabismus during the evolution because this is chronic or after surgeries. And think in mind that these thyroid people are very, very great. They have a very great functional capacities. So less deviation is better for them always. Some examples is this in a case of esotropia, you can see here the inflammation in the lids, in the tissues. And then after botulinum with a little exotropia, you're not going to find a big response like in congenital esotropias, for example. And here completely corrected the initial strabismus. And because this kind of strabismus, a small strabismus, can be before of the rest of the signs, you can begin to treat in the same way at the same time. And you can see here the technique that we use to direct injection since 1995 in a hospital. And then this is in cases when the patient never can be operated because you know that they have another morbidities. This is an example of esotropia and this vertical deviation. And then after treatment, you can push to the patient to other treatments. And this case with a very good resolution with esotropia and vertical deviation. And you see here the aspect after treatment with botulinum without any surgery. And in some cases like this, adding toxin in the same muscle like this. So we were injecting in the inferior rectus, and then again, and then again. And you can see here after 6 months of treatment, the position is very well. In this case, it's an exotropia. So you can see here the treatment in both lateral recti and also in the superior rectus here. You can see the effect in the lid. So after the injection, the position is very well, it's a good response. And also in this case, more than the treatment of the vertical deviation, you can add more toxin in the lids and you have a double effect. After surgeries, the decompression is not uncommon to see deviation, strabismus that new strabismus because of the surgery. And you can see here after the botulinum, immediately after of the surgery, you can inject the botulinum and again a photodirect technique. this is a case. You can see here the inflammation, and the patient is beginning the treatment of thyroid disease. And after decompression, you can see here the position is completely changed. So we put some botulinum in inferior rectus and also in the medial rectus. This is after botulinum. And finally, this is after recess of both inferior rectus. So when you are using botulinum, you can reduce the deviation to do, if you need to operate, a less surgery or less number of muscles. So the things that I want to share with you is, remember that in thyroid disease, you can use more toxin. Even in the thinking of the starting dose, you can increase the doses. But the most important thing is that you have, or you can add more toxin in the way of the treatment to keep or to maintain or to improve the effect in strabismus, because the strabismus is one of the most problem in the way. When we perform research in the strabismus patients, even without any other signs, we found the level of natural killer was too high. So I know that we are watching many problems in one disease, because that's why maybe the effect, as you are hearing, the effect of the nerve, optical nerve, it could be also the problems in the family of antibodies. So this is my presentation. I wanted to share that idea. And finally, I want to invite you to remember that we will have the Congress of the ISA in 2022 in Mexico. In the time, you can be a member in this page. And also you can find some information of the Congress in this other page. I am Silvia Moguel, and thank you to all of you.
Thank you, Sylvia. If you can stop sharing your screen. That was fabulous. Our Botox experience mirrors yours, and we published that with the larger doses. I think that it's important to raise this issue, in part because many people think because there's a fibrotic change in thyroid disease in the muscles that Botox won't work, but it still makes a difference, doesn't it?
Yeah. I think that, because we never know, we cannot know how is the fibrotic part and how is the inflammation part. But even if the patient has 10 years, for example, it's a chronic patient, try to do the opportunity to move more the muscle and the effect of higher doses. Because the problem is in worldwide, in all the world, the people think that one dosage is similar to whatever. And they say if 10 units, 5 units didn't work, never is going to work with something else. And it's not true. We found a very, very related effect in the muscle, increasing the doses. But the second idea is to add the doses in the way. So, because the problem is that, you know that new sprouts are growing and relating and liberating acetylcholine. So it's the moment to increase the effect of the muscle, of the degeneration. The degeneration is as high as you could see. So that's why it's important, because you know that operating the strabismus in the thyroid patients is difficult, because they are going to have some recurrences, and sometimes you don't have any other muscle to operate, and you have to operate very, very small amount. That's why if you botulinum, it's a good idea.
Yeah, even if you can make the deviation less before you operate, that's valuable, right?
Yeah.
So that's good. Don, I know that you've done some work with Botox at the time of decompression surgery.
Yes, thanks. I was just going to bring that up, David. It's one of the fruits of having in-depth discussions with you about Botox and how to treat these patients. So, when we get minds thinking about the same problem, we start to look at it from different angles. And one of the things that I've tried is giving botulinum toxin injections to the muscles at the time of decompression. And for those of you who perform decompression, we often open the periorbita, and you're staring at this big muscle that kind of just falls out of the periorbita. And then, so in cases, for example, a large angle hypotropia, the inferior rectus is huge, we would give 10 to 15 units of Botox intraoperatively at the time of decompression. We've seen some good results. It's hard to control for that, and I think some of them do get strabismus surgery eventually, but like you just mentioned, it can reduce the deviation, which makes it easier for the strabismus surgery.
So,
Well,
just one question for Dr. Granite. How often, how much, and when do you give the Botox? During the active stage, cicatricial stage?
Yeah, I would agree with what most of what Sylvia said in her fabulous discussion about when to intervene and how you're intervening. I'd like to get it when we're, if I can get the patient to agree to do it early, I'd love to get it early before we see the large deviations. And I use similar large doses. And years ago, when I first started, I discussed this with Alan Scott, and he does the same thing. And everyone who uses Botox and thyroid has either accidentally discovered or realized that you must use these larger doses. So
when you say larger
just
doses,
as Sylvia said,
larger meaning how much? 10?
Yeah,
10
is
units?
it 20? Is it 20 units, 25 units, 30 units?
Yeah. I begin usually with, for example, for a small deviation in thyroid with, for example, 15 units. But if I see a large hypertropia, this is the most common, I begin with 20, not less. And I prefer to inject before of any decompression, because when the surgery is going to be performed, you can find then a longest muscle in the way. So I prefer to inject, for example, 1 month or 1.5 months before any surgery to have a long, a weak muscle before of the surgery, because in the time of the recovery of the surgery, in the fibrous or in the cicatrization time, we can get a weak muscle in that moment. That's why I don't like in the moment of the surgery, but before, right?
So
what about just in patients with active disease? Would you miss a concomitant, like sort of myasthenia gravis if you're thinking about injecting the Botox? So do you ever concern about that?
Yeah. You know that we did work in all of the morbidities in this disease, and we can find many patients with myasthenia, and also lupus is the second one. So I don't have a problem. And I wrote a paper talking about treatment in myasthenia strabismus since 1998, something like that. And I discussed with Alan Scott, because you don't have to feel fear using in myasthenia, because you are injecting just the contracted muscle, not the weak one, right? So if you have a exotropia or whatever in a myasthenic patients, even if having thyroid disease at the same time, you're injecting just the strong muscle. So you're not going to have an effect in the disease, in the myasthenic problem, and you're not going to have an effect running in the weak muscles. So it's not a problem.
So what I gather
this is awesome. Wait, I'm sorry, Madura.
Okay.
Sorry. But you can see why we booked 2 hours for this webinar, because any one of these topics, we could go on, and we have a world of expertise. It's also a reason why we have neuro-ophthalmology, oculoplastics, and strabismus people here together, because without us being together, none of these discussions happen. You can see the appetite for this. Jenny, our moderator, will be up next for the discussion of, okay, so we finally got to the patient that needs something done. What do we do? And we'll talk about what we may call one day the old-fashioned surgery, I guess, orbital decompression.
True. And even though I'm an orbital surgeon, I do hope that we have better medical treatment for this disease more than just the surgery itself. So let me get started. I do have financial disclosures for Horizon Therapeutics. And of course, in this disease process, we want to be able to diagnose early and treat medically. And inevitably, though, we're still going to have patients who progress, and those progress to severe disease in which we have to intervene with surgery. So in that acute inflammatory phase, clinical activity scale of a score of 8 to 10 with either exposure keratopathy, optic nerve compromise, or spontaneous globe subluxation, we're decompressing these patients sort of in an urgent, emergent manner. As you know, this disease in the chronic quiescent phase is still very disfiguring for patients, and that affects their overall sort of mental health. And so in times of chronic disease, we think about this as a rehabilitative surgery and improving aesthetics and restoring the appearance and improving their subjective ocular surface symptoms. Just a little bit of the anatomy. We obviously have an orbit that's a fixed volume of a 4-wall pyramidal shape. And our goal here is to be able to remove the bones so that we can create more volume for that expanded tissue through the inflammatory phase. Historically, there are ENT or maxillofacial, plastic, and neurosurgeons who will approach the orbit from various options, transantral, transcranial, transnasal, and obviously orbital approaches. But I think as surgery has evolved, and with oculoplastics and orbital surgeons and the advent of CT imaging, we have so much more options now and to think about the surgery and how we can really have customized solutions for these patients. So we have all these hidden incisions around the periocular soft tissue in which we can approach the orbit in various walls. Typically for us, we get a CT scan to sort of analyze the volume, especially in those unilateral asymmetric patients where we can compare the volume expanded in the one side to the other side. We'll give steroids if needed to sort of reduce that mechanical decompression that Madhura had mentioned earlier, and just creating some room in the posterior apex. And then we'll do this graded approach in using a CT scan and analyzing and figuring out whether we go with just bony decompression alone or bony decompression plus soft tissue and fat decompression to create the room that's needed for the patient to reduce a compressive optic neuropathy. A survey in 2017 of most ASAPers members show that the preferred approach to an orbital decompression is a 2-wall balanced lateral and medial wall decompression. That is the most common. And with floor and medial wall decompression being sort of the next standard. A 3-wall is needed if there's the need to sort of create more room. I think with a 2-wall balanced lateral wall, medial wall decompression, you can create about sort of 6 or 7 millimeter of decompression. And then canal decompression sometimes is done if the disease is much more posterior and the optic nerve is compromised. And sometimes we'll use our ENT colleagues to do an endoscopic sphenoid sinus removal so that you can see the picture here last, that the optic nerve then is release of the sort of pressure there. And obviously with the complications for any orbital decompression, there's CSF leak and strabismus, and worsening strabismus if they don't already have strabismus to start with. Some of the things I kind of want to talk about and for discussion as well are just, since we have a worldwide audience, that there are orbital depth changes in different ethnic groups. And the trigone size in that lateral wall can really affect how someone gets that optic neuropathy early or not, in that thickness of that greater sphenoid win. And I'd be interested in hearing Dawn's comments for this. And in patients who are younger in the pediatric population with thyroid eye disease, they tend to have milder presentation, not so much proptosis. So then the question is, will they require a decompression? What do they present like? And then with the elderly population, they get less proptosis because of the orbital fat atrophy, just that happens with aging, but they do have more risk for optic neuropathy because their muscles are enlarged much more. So I do want to then just pose some questions for discussion in terms of everyone's sort of approach for their preferred approach for orbital decompression. And then we already kind of touched on this already with Sylvia in terms of just the utility of Botox injection during decompression surgery. And it sounds like most agree that that's what we like to do. And given that we have biologics and Tepezza, how do you see the treatment of the paradigm shift in terms of decompression's role in treating these severe diseases? Thank you.
Fabulous, Jenny. Thank you so much. We're going to go right into our other oculoplastic talk and then combine this for a discussion when we can talk about when to put in each and how to take care of the patient now, and take the questions that you raised and combine them with the ones that Don will raise. Dr. Don Kikawa from San Diego, you're up next.
Thank you, David. I want to give a big shout out to both David and Ken Nischel for being the visionary leaders to start the society. And it's been great to have these events and bring people together and bring different insights into many difficult problems. And I want to thank you also for inviting me to speak at this symposium. It's been great. So I'm going to talk a little bit about biological therapy. Here are my disclosures. So I used to end my talks on thyroid eye disease with this slide. And we always thought that surgery was effective, but in the future, we also thought that medical therapy is probably going to be the main treatment for this disease. And as Jenny pointed out, we've gotten pretty good at surgery. So surgery still works, but I think the spectrum is slowly shifting to medical therapy. But we have to first discuss what is medical therapy useful for. We have to look at our endpoints. So we talked a little bit about clinical activity score. And it was thought that a lot of the medical treatment helped to reduce inflammation, but it really didn't change the endpoint. So the endpoint that most of the studies have looked at is proptosis reduction. And then the motility is another endpoint that I'm sure we'll get into discussion about. So just broad classes of medical therapy for autoimmune diseases. There's mainly four. There's non-steroidals, steroids, cytotoxic agents, but we're primarily going to be discussing biological response modifiers, which are monoclonal antibodies. There are some differences in the way monoclonal antibodies are produced, and there are some that are primarily mouse, some that are a mixture of mouse and human, and then there are some that are primarily humans. And you can tell by the name of the monoclonal as to which family they're in. So XIMAB is primarily mouse, ZUMAB is a mixture, and MUMAB is primarily human. There have been primarily three biologics that have been used in thyroid eye disease. The first to be used was rituximab, and you'll notice this is almost all mouse. This is an anti-CD20, which has been in use for over 20 years for lymphoma. It was used off-label for thyroid eye disease. The second that was used was tocilizumab, which is an anti-IL-6, and you can tell by the name that this is both mouse and human. And then finally, the third one that has been used is teprotumumab, which is an anti-IGF-1. And this is primarily all human. And in the US, it's been FDA approved since January of last year. I have to give a big round of applause to Terry Smith, who was pretty much the pioneer of teprotumumab. And how does teprotumumab work? It's kind of an interesting mechanism. So the IGF receptor and the TSH receptor are co-localized on the orbital fibroblast. You can see the IGF receptor here in green. So the thought, and it was brilliant on Terry's part to think that if you block the IGF receptor, you subsequently block the thyroid stimulating antibodies. So it kind of works as an innocent bystander type blocking mechanism. The infusion, it's given by infusion. It's done over a course of 28 weeks with 8 infusions total, spaced out every 3 weeks. And the dosage that the FDA recommends is 20 milligrams per kilogram. I'm going to show a couple cases just kind of showing our experience. So this is a 71-year-old gentleman who presented with puffiness and swelling over 6 months. He was experiencing diplopia and extreme gazes. He actually had a thyroidectomy from RAI, medical thyroidectomy, several years ago, and did not have any eye symptoms for many years. And then suddenly his eyes started to swell. You can see on imaging, he's got enlarged extraocular muscles. Here he is after 8 teprotumumab infusions. So his clinical activity score pre-treatment was 4. Post-treatment, that dropped to 0, and he had a 3 millimeter reduction in proptosis. So this was the classical patient that was studied in the clinical trials. Another kind of thought-provoking case that we actually reported was what about the patients that have had a longer history? Is it effective in those patients? And this is a patient with a 3-year history of Graves. For 2 years, the eye condition was stable. The proptosis readings were 28 on the left eye and 23 in the right eye. Only a CAS score 1, mainly for retrobulbar pain. So this is the type of patient in the past we would have taken to surgery. There was no indication to proceed with medical therapy. And you can see with teprotumumab, only after 3 infusions, she's had a marked reduction of proptosis, even on imaging. Her muscle size has reduced, and she's had 5 millimeters of improvement in proptosis, as well as a reduction of her CAS score to 0. There are some potential side effects with teprotumumab. Hyperglycemia needs to be monitored. Muscle cramping is probably the most common thing we see. It is very teratogenic, so pregnancy should be avoided. And then there have been reports of tinnitus and hearing loss. And I think the big questions that Dr. Yu asked is, where does teprotumumab fit in? We've seen 2 cases here, one kind of in an acute setting and one kind of more in the chronic setting. Both have been effective. There are some costs involved, and also, you know, there is still the possibility that surgery does work in these patients, but do we offer them medical therapy instead? So I used to end my talk with a slide I showed you, so I have to come up with a new slide to end this talk. Right now, we're kind of in this one-size-fits-all medicine. We have a biologic therapy that works, but in the future, we probably will subcategorize. We'll get more specific as to how we treat these medical patients with gene profiling and RNA sequencing to actually come up with different medicines to treat different subtypes of this disease. So with that, I'll end. Thank you very much.
Don, thank you for that.
Thank you, Don.
Sorry, David. I have a quick question. So when you talk about that chronic disease and how that react, I mean, I know that this, Tepezza was first used in just acute inflammatory phase. And I know that there's probably some inflammation still around. What are you, I mean, I know you showed the case. What would you say in terms of chronic disease, in terms of using the biologics?
Yes, that's a good question. So I think part of our interest in using it for this broader indication of patients was based on the FDA approval here in the US. So even though the clinical trials were very specific as to what they included, they needed active disease, they needed a very short, I think it was a 9-month duration. The FDA approval was actually very broad. It was approved for thyroid eye disease, and they didn't really differentiate as to what phase of the disease they were in. The patient I showed actually was offered surgery, but had comorbidities that precluded her from having general anesthesia. And we thought, well, you know, we don't really have anything to offer her. So we got her insurance to approve teprotumumab, and we gave that. So I think we're kind of still in this deciding phase as to who actually should get the medicine. As I mentioned, there is some cost involved. And I think right now, if we can get their insurance company to approve it, I think if we can try the medicine first, it's worth it to try. And then if it's not effective, then I think these patients may benefit from surgery. But I don't know if it's quite first line therapy yet. It's getting very close, I think, in our practice.
It's very exciting. Just for the worldwide audience, I know this medicine is only available in the US. But hopefully this will expand.
So, I mean, from a perspective of a strabismologist, you talked about proptosis. We're going to have a whole section coming up next with our strabismus speakers. I didn't hear a lot about what happens to the strabismus. And when I look at the data that's out there, I see scales I've never seen before. A Gorman scale was used in the trial for the FDA, and I've never used that as a strabismologist. And I don't know how much the deviation changes. I don't know where this fits into the strabismus model. And I'm wondering if anybody has any insight into that.
Yes. So, I think you hit the nail on the head. I was just going to mention that, Dr. Granite, that in the actual trials, they used a Grommet scale. I had never heard about that. It's basically looking to see if they have diplopia in primary and side gaze, and it was very subjective. So I think the next step is that I'm following a few of my patients now who don't have a very high clinical activity score, that had progressive double vision, that are now getting teprotumumab. Of course, it's halted now because of lack of production. So we are in a little bit of a stagnant phase here, but it'll be interesting to see, because we are doing actual measurements of their double vision, not just sort of, well, is it better, is it worse, but actual measurements in their primary position and gaze of maximum deviation. And I think that would be very helpful to know as well.
Yeah, and I asked because Don and I are doing the same thing in San Diego, where we're following those measurements, because we don't know the answers to this question. And it brings the idea of, when do we intervene? I mean, as soon as someone's immediately diagnosed, before they hit Rundle's curve at the high point and have all this horrible disease and risk optic neuropathy, should we be treating as a prevention? What's the role of this drug?
Well, Dawn will tell you, and so will Jenny. I mean, the biggest hurdle has been insurance coverage. I mean, it's taking 4 to 6 weeks, up to sometimes 8 to 10 weeks, for insurance companies to approve $250,000 worth of infusion over 6 months. I think that's the biggest hurdle. Your patient with that chronic optic, chronic double vision, and, she probably had great insurance. But I think, if you want your patients to get Tepezza, I want them getting it tomorrow. It isn't happening. They don't get it for close to 2 months after diagnosis, primarily because of
Tony. So
Well,
Tony, will the NHS pay for this?
Yeah, I was going to mention that. So the NHS is not going to pay for this, and I'll ask Don, do you really think there's a time where the costs of this are going to come into the realm of us normal people, where, I can see giving this really early and you're going to put me out of a job, which, I'm old enough to need to be put out of a job probably, but
I'm sorry, go ahead.
Do you think there's ever going to be a time where we're going to give this really early and prevent strabismus in thyroid eye disease?
So I think that there is still going to be a need for our services going forward. I don't think everyone has a uniform response of cure with the medicine even. And David and I had thyroid clinic this week, and we saw patients that have actually been treated. They've gone through their full cycle, and they're still going to need surgery. So I think right now we're sorting out who best should get the medicine. And I think it's probably there's going to be some patients that don't respond. It may be the type that is not this explosive inflammatory type, the ones that have the very slow, low CAS score, predominantly fat infiltration. I'm not sure those are the ones that benefit as much as the myopathic thyroid disease.
Mm-hmm.
I also just want to bring up too in this discussion that, we are fortunate to have this drug in the US, but for majority of the world, steroids has worked. And so I just want to ask Mohammed here, sort of what is your medication of choice, and elsewhere too in your practice, how you treat the active disease?
In my country, actually, we start with we don't have options in here except for steroids, IV or pulse therapy or PO, and then followed by radiation therapy for 10 sessions. And then at times we can start with other immunosuppressive treatment, such as methotrexate and cyclosporine. But the breakthrough of temoprimumab, it is actually in here, it is difficult to just afford it, actually. It is a breakthrough in the treatment of thyroid eye disease, but it is difficult, actually. We don't have it in here first, and we're waiting for the generic of the drug just to come over and if it is affordable or not. So this is why we don't have weapons in here like in the States.
And so how about in Singapore? What are your options in Singapore for medical treatment?
we have steroids and we have the older biologics.
Is
David,
it difficult?
I wanted to say something about you were asking about the strabismus problem, because sometimes, because they have a very high functional capacity, you don't see the strabismus. So only if you look for that and you begin to break the function, then appears the deviation. So sometimes you don't know how long the patient is running the problem, the disease, maybe many years before, when they feel the first symptom. And that's why this is the importance of looking exactly for the strabismus, or to look the limitation in the abduction, that is the first sign sometimes, not especially the hypertropia. So I think that we were working in the hospital all the time, the Department of Oculoplastic and also the strabismologists, because they cannot be separated in this disease, especially in this disease. They have to work together all the time.
It's so important to educate our colleagues as well. We spend a lot of time talking to endocrinologists so that they can get the patients to us early. Strabismus has come up a number of times now. And so I'm going to ask our Strabismus team that we've assembled from around the world to get ready and put up their slides so we can segue into the Strabismus component of this, which I'm chagrined to say is becoming last in our talk as a strabismologist. I think, Tony, are you up first in this?
Can I share my yes.
So while you're putting up your slides and sharing your screen, I'll mention that we have Myanmar, Indonesia, Russia.
Okay, my slide okay. So hi everybody, thank you David and for being me in here in this excellent webinar actually. So our strabismus lecture will be divided into 3. I will start first with a bit of tips to be followed in strabismus surgery and thyroid eye disease. And so the Dr. Leo will talk about the techniques of the surgery, and Dr. Vivian will talk about the complication of the strabismus surgery and thyroid eye disease. So as we just know, so it is a crowded house, actually, with muscle involvement and fibrosis with concomitant strabismus. And we mentioned that strabismus is found in 17 to 51% in thyroid disease, where diplopia is the initial presentation. Active inflammatory, we have 2 phases as mentioned before by our colleagues. So we have active inflammatory phase lasting 1 to 2 years and plateau phase. And the restrictive myopathy and double vision are found in both active phase and plateau phase. So we have medical and conservative treatment for the strabismus in the active phase. First, we have to tell the patient to stop smoking, and we have all the medical treatment mentioned by Dr. Kikawa, and the teprotumumab, which is a breakthrough, as I mentioned myself. And strabismus surgery should be avoided in the active disease. And diplopia treatment will be just done by monocular occlusion, prisms, and Botox. Prisms can be used to restore binocular single vision in primary and reading position, the active and plateau phase, even after surgery for residual strabismus, or in patients who cannot undergo surgical intervention. It can correct vertical and horizontal diplopia and can alleviate head posture. And we have 2 types of prism, the Fresnel prism, as you know, and the built-in one, and with the side effects, blurred vision, diffraction, and some people, they couldn't tolerate them. Botulinum toxin. So we have 2 studies, 2 main studies, one from our moderator, David Granite, and also Dr. Kikawa, and by Chris Lyons from Moorfield Eye Hospital. The studies have shown that more than 30% of patients did not need further surgery after botulinum toxin injection. And 40 to 70%, they improved in the angle of strabismus, and it is most effective in patients with small angle. So it can be also done after strabismus, as mentioned by Dr. Sylvia, for residual cases to avoid reoperation. What I do myself, I inject the inferior rectus through the lid, not in direct vision as Dr. I use 10 international unit for botulinum toxin to inject the inferior rectus or other muscles in thyroid eye disease. We just mentioned about the classic stage paradigm. We start with orbital decompression and then strabismus surgery, eyelid retraction repair, and blepharoplasty. And hope all the patient will be just in the like this patient, just with good alignment and good ocular eyelid repair. So if we want to do surgery, surgery is indicated in case of significant disability in functional position of gazes. And the parameter to be taken into consideration are constant double vision and stability of the patient disease. So this should be just coordinated with the endocrinologist and stability of the deviation for at least 6 months. And sure, the surgery, as mentioned, should be carried out after orbital decompression in case of any change in the angle of the deviation. Achieving optical outcome in this patient remains challenging, especially in vertical deviation. And this should be extensively discussed with the patient before surgery. Imaging are of help before the surgery to look for muscle thickening. And also MRI can just assess the disease activity and increase water content, as mentioned in the previous talks. That can be indicative of active inflammation and have predictive value for the response of immunosuppressive treatment. Imaging should be performed after decompression surgery to look for any muscle incarceration. And also imaging can help to differentiate between thyroid eye disease and myositis, because in thyroid eye disease, you know that the muscle belly is involved and the tendons are spared, indifferent to myositis and other orbital lesions. What are the aim of surgery is to improve the quality of life, because most of the patients, they have double vision and they are disabled and they cannot even drive or walk or perform their regular life. So also to improve binocular single vision in primary and reading position, and to alleviate head posture and try to expand the binocular field of vision, and also last but not least the cosmesis. And always aim for undercorrection in surgery. First, we have to examine the patient in all cardinal position of gaze and record the limitations. And we also have to just assess the primary, secondary, and tertiary function for each muscle. And also sensory motor tests are helpful. And we should keep in mind the coexistence of myasthenia gravis and thyroid eye disease, especially in cases with exotropia rather than esotropia and presence of ptosis. Force reduction test is to be performed pre and intraoperatively to assess the severity of the restriction of the involved muscle. And weakening of the muscle is the surgery of choice in strabismus for thyroid eye disease. All the extraocular muscles are involved, with inferior rectus involvement is the most common, followed by the medial rectus. And patient may have vertical, horizontal, or mixed strabismus depending on the muscle involvement. We have to avoid resection, not to aggravate the inflammation, and this can cause muscle fibrosis. And resection are only left for large deviation and to a less inflamed contralateral, non-involved muscle. Restricted and fibrotic muscle do not follow standard surgical nomogram. There is no specific nomogram for thyroid eye disease cases in strabismus, and there is no general agreement for surgical dose response. So in strabismus, dealing with strabismus with thyroid eye disease, we know that the conjunctiva is very thin and friable and should be handled with care. And the tight muscle makes exposure difficult. What I use myself is just use 2 hooks as a spacer in between the muscle to just fill in the needle, and also to try to cut the muscle piece by piece, not to just have any rupture or avulsion, especially when handling it and cutting it for this insertion. And reoperation in thyroid eye disease is very common and can go between 20 to 50%. This is why adjustable suture is in the picture. What I use myself is adjustable suture using absorbable suture. I do early adjustment and beware of muscle slippage or overcorrection in adjustable suture. Some, they use non-absorbable suture to prevent overcorrection, but this might increase infection rate and suture exposure or granuloma formation. The other techniques will be just elaborated by our colleagues later in the lecture. This is a patient of mine who is a mathematics professor, 55, he presented at the age of 55-year-old with thyroid eye disease and stable thyroid function. He had 30 diopter of horizontal diplopia, and he underwent BMR recession, one unadjustable with orthophoria post-operatively, and he's been stable for the past 15 years. Thank you very much.
The Strabismus team will keep going. Mohammed, you have to stop sharing so that the next person can put their slides up.
Okay, I'm up next. So I'm going to talk about some specific tips and tricks for strabismus surgery. As Mohammed has said just now, you have to use prisms to minimize diplopia before and after surgery. The other thing to remember is these patients cannot elevate their eyes. So sometimes they cannot fixate through the top distance segment of bifocals. So you either lower the bifocal segment or separate the glasses into one pair for distance and one pair for near. The other thing I always remember is to communicate with my anesthesiologist. We have to make sure that the patient is clinically and chemically euthyroid, but do expect that sometimes the airway could be difficult and peri-op airway complications can be a problem. This is especially so in those patients with very big goiter or they have a higher risk of post-thyroid resection, tracheomalacia because of the prolonged pressure on the trachea. Also, because these are very tight muscles and pulling a little bit harder, there is a higher risk of ocular cardiac reflex. The general plan of things is to remember that the surgical tabers may not be as useful. I find that a lot of times we need smaller than normal recessions, especially if the deviation is very large. I also use adjustable sutures to fine-tune the results, and I have to anticipate and reduce the risk of late overcorrection. Again, Mohammed talked about the conjunctiva. We have to remember that a lot of times these eyes are hypotropic for a long time, and the conjunctiva could be shortened inferiorly, and they will need conjunctival recession. This is the most common surgery we do for hypotropia in thyroid eye disease, the inferior rexus recession. Tapers have said that 1 millimeter of recession corrects about 3 prism diopters of hypotropia. But again, I find that it really varies. So again, the decision is, do you do the recession alone, either one unilateral or bilateral IR recession, or do you need to also recess the contralateral superior rectus? This really depends on the amount of deviation and the force duction testing findings. To work out whether you're going to recess both or one inferior rectus, it really depends on whether it's one tight or both tight. Before the surgery, we can do monocular occlusion of the more severe eye, the more hypotropic eye. If it resolves the chin-up posture, you know that you can just get away with unilateral IR recession. But if not, we would have to resort to bilateral asymmetric IR recession. A lot of times, sometimes the primary hypotropia can change, and that could actually be a sign of progressive bilateral IR involvement. Intra-op force duction testing is extremely important, and depending on the tone of the superior rectus, you may have to fudge your planned ipsilateral inferior rectus recession. Also, there are these severe cases that even after you completely detach the rectus muscle, you can't move the eye. And then you will know that these patients cannot be completely aligned. These are the very, very severe cases where there's just mass of enlarged muscles in the restricted orbital place. So even, even removing all the muscle incisions, there's still a lot of restriction to globe movement. At the same time, when they're doing our intra-op force duction testing, do not forget the obliques. It is very important to do the exaggerated traction test of the superior oblique after you've taken off the inferior rectus, because a very, very tight superior oblique can worsen the A pattern in torsion. Like Dr. Yunus, I also use adjustable suture and with absorbable. bearing in mind that we would anticipate like a late overcorrection, a hypertrophic shift, when I do my IR recession, I adjust for undercorrection on the day of surgery. I aim for ability to fuse with 5 to 10 degrees chin up position. However, if I'm doing a medial rectus recession for esotropia, I do not undercorrect so much. I adjust to near ortho unless the medial rectus is very, very tight. Dr. Vivian will talk about more details about this semi-adjustable hangback technique later. As for suture material, I tend to use absorbable because I do not like the granulomas that you get with non-absorbable sutures. During the surgery, we have to take care to avoid muscle rupture of these very, very tight muscles. Since my fellowship days, I've liked to use Dr. Wright's right groove tool, which is really very elegant. I also have had the pleasure of receiving a Koa hook from Dr. Lionel Koa, and I also use it sometimes. During the surgery, we could also decide where we put the muscle by using the intra-relaxed muscle position technique, where you recess the muscle to where it wants to hang once disinserted from the glove. And torsion can be monitored intraoperatively with the use of a skin marker and a Mendes ring. Of course, lid retraction is the one we worry about because of the associated IR recession. So it is important to clear the inferior rectus from any attachments to the inferior oblique and lower lid retractors and lobal ligament. Dr. Anthony Vivian will talk more about this later. Techniques that have been used to prevent lid retraction include capsular palpebral head advancement, retractor lysis, even though I don't really do these. Sometimes I use a temporary suspension suture if there's a lot of swelling and there's also associated ectropion. Another feared complication is a post-op A-pattern exotropia. This is because, remember, the inferior rectus secondary action is adduction. So when you do very large bilateral inferior rectus recession, it will weaken the adduction in downgaze and it will stimulate your superior oblique action in downgaze and you get very bad A-pattern. We need to anticipate this pre-op. And if you try to do a medial shift of the inferior rectus or supraplace the medial rectus, it may actually worsen the intorsion. So one possibility is to try to nasal collapse the inferior rectus insertion, which means you only nasally shift the temporal insertion. Intorsion can happen resulting in diplopia by various mechanisms, sometimes after your initial strabismus surgery. In those cases which do not have previous strabismus surgery, they can actually get intorsion following orbital decompression because of increased tension on the superior oblique. And I've had the pleasure to learn from Dr. Del Monte during my fellowship days, where he showed a very elegant technique to correct symptomatic intorsion by transposing and advancing the inferior oblique. So it's like the equivalent of the superior of your Harada Ito. So in this case, you advance the inferior oblique and superior transpose it to a position that is 8 mm posterior to the superior border of the lateral rectus insertion. And each transposition can correct 10 degrees of intorsion. What about resection? Although it does increase muscle stiffness in already very tight, inelastic muscles, I find that if there's very significant esotropia and hypotropia and diplopia, even though you've done large medial rectus or inferior rectus recession, there is still a place for judicious resection of your lateral rectus or superior rectus, and small resections are preferable. Thank you.
Oh, yours, Tony.
I'm getting there. Well, thanks very much. I'm just gonna... Thanks, Mohammed and Salwe. I'm going to talk. So you've done fantastic surgery, and you think that you've made a huge difference, but it doesn't necessarily go how you expect it. What do you do, and how do you find out what's gone wrong? The most common problems we're talking about is what's known as late overcorrection after inferior rectus recession. This is usually after unilateral recession or asymmetric recessions. I'm going to talk a little bit about lower lid recession after inferior rectus recession, a bit about torsion, and probably the most common complication is failure to meet the patient's and the surgeon's expectations. the late overcorrection, this is something that we fear, and I think it's a pretty bad name for it. I like to call it reversal of hypertropia. It's rarely due to the muscle being in a different place compared to where you think you put it. That means it's not the surgeon's fault, but it depends how you've done that recession. The causes of reversal of hypertropia, yes, it may be that the inferior rectus muscle has slipped backwards from where you put it. It may be because the recessed inferior rectus is damaged by disease and it doesn't work as well as you think it's going to do. So you've got a weak inferior rectus as well as a tight one. Could be due to contralateral inferior rectus restriction, and this is probably the largest cause of reversal of hypertropia after inferior rectus recession. But it could also be due to ipsilateral superior rectus being affected by thyroid inflammation and is tight. And to make things complicated, it could be a combination of all of those. So thyroid inferior rectus damage is an unhelpful combination of loss of stretch, causing a tight muscle, which limits elevation, and loss of strength, causing a weak muscle, which limits depression. And what we need to find out is which is the most common cause, what's causing the problem. So how do we tell what's causing the reversal of hypertropia? Well, as usual with strabismus, assessment is key to unlocking the truth. Yes, we need to do Prism-Cuzzer tests in 9 positions of gaze. We need to look at the versions and particularly the ductions of all 12 muscles to find out which muscle is responsible. Look at the scans and look at the scans again. Do forced duction tests. Forced duction tests can be done in the clinic room very straightforwardly. I tend to lie the patient down, otherwise they might end up on the floor and you have to pick them up by yourself. And you do forced duction tests with local anesthetic on the eye. It really gives you a good idea about which muscles are affected. So this patient is 3 months post-op a right inferior rectus recession. Has the right inferior rectus slipped back here? Well, it's a natural assumption to think it has. She's got a hypertropia, where she used to have a hypotropia before surgery. The lower lid is recessed, and the down gaze is limited. So if we put this muscle back too far, has it slipped back after we've done it? Well, reversing the original surgery, which seems so tempting, is rarely the solution. So why would an inferior rectus slip back? Well, if the unique thing about the inferior rectus is that there are a few things attached to it. There's the lower lid retractors. It shares a sheath with the inferior oblique, and gravity wants to pull it away from the eye. So if we use adjustable sutures, particularly absorbable adjustable sutures, the inferior rectus is not opposed to the eye. Some fibrosis occurs as healing is happening, and once the suture dissolves, the inferior rectus then slips back. So this is one reason, if you're using adjustable sutures, why the inferior rectus could slip backwards. The solution to this is don't use adjustable sutures. The problem with that is we want to use adjustable sutures because inferior rectus surgery in thyroid is very unpredictable. The outcomes are very unpredictable. And I'm going to talk a bit later about this semi-adjustable suture, which allows us to adjust it, but also allows us to attach the muscle to the eye. So these are the two questions we want to ask. If the inferior rectus hasn't slipped back and ended up in a different position, how tight is the superior rectus? Because if the superior rectus is tight, it's pulling this eye upwards against a recessed inferior rectus. And the second question is, how tight is the inferior rectus on the other eye? Because answering those questions is going to determine what surgery we do next. I'm not going to talk about toxin, by the way. So look at the scans carefully. So MRI scans and CT scans are both really useful for looking at the muscles. So axial scans are excellent for looking at horizontal muscle positions. But in order to look at the vertical muscles, we need to look at a sagittal view. In a CT scan, you can ask your friendly radiologist to reformat the scan and give you a sagittal view. But with MRI scans, you have to order it. You can't reformat it after it. So you need to ask for a sagittal view. And then you can see, is this superior rectus? So we've recessed this inferior rectus. But the reason the eye's gone up is there's a huge superior rectus up here, hauling the eye upwards. So then we know we need to approach that as the source of our next operation. And we need to look at the inferior rectus on the other eye. So looking at scans, really important. You need to do sagittal scans to look at the vertical recti. Force duction tests, we've already mentioned that never forget the obliques. The obliques are affected by thyroid eye disease, and probably more commonly than we think. And force duction tests, in the clinic, I tend to use one pair of forceps rather than two. It's a little bit kinder and a little bit easier. I put a little pledget on using tetracaine on the eye, and then I move the eye to see how tight the muscles are. It's a really, really useful test if you want to find out which muscles to operate on. So in terms of surgical management, redo surgery is the same as primary surgery. We need to remember that thyroid-related muscle disease involves a myositis, followed by fibrosis and shortened, stiffened muscles. Impairment of rotation is caused by mechanical restriction, but also the muscles don't contract normally because they've been affected by the disease. And the whole orbit is involved, but it may be asymmetrically involved. I was just going to mention briefly torsion because Saway's already talked about it, but torsion may appear after the first operation, and it may appear because the vertical and horizontal deviation is too big preoperatively to see that there is torsion. So it may have pre-existed the surgery, but was not obvious. And then rectus surgery, as we've mentioned, can cause or exacerbate torsion. And we need to look at the MRI as well, because if we look at this MRI here, you can see this is a coronal section. You can see a great big superior oblique here. So looking at the MRI can give us really good ideas, but then force duction tests using the obliques is important. So I'm going to briefly go through some slides looking at inferior rectus surgery using this semi-adjustable technique, which I first found out about at a breakfast with the experts with Bert Kushner, and he told me about this. And the important thing about it is it limits, it allows us to do adjustable sutures and still attach the muscle to the eye. And the concept of it is we do a fixed recession of the inferior rectus, and then we have a central adjustment suture in the middle. And we look for this is looking at the inferior rectus from the surgeon's point of view. We look at the anterior ciliaries. We do our I've done a limbal conjunctival incision here, hook the muscle and spread the muscle out. We've already talked about grooved hooks. There are lots, this is called an ASAF hook. There are lots of different grooved hooks. They're really important in tight muscles because we can put the suture in without risk of perforating the sclera as we're putting it in. The important thing is removing these lower lid retractors, which is going to reduce the amount of lower lid recession post-surgery. I use a Fison, retractors are really important, and I use a Fison's retractor. There are lots of different retractors. This has a nice broad base, but a long arm, so it makes it easy for us to see. And we retract, when we retract these tissues, we can see the lower lid retractors coming onto the inferior rectus. They're little white bands, and you can twang them with your scissors. They're very tight, and we need to cut all of these low lid retractors off. You can reattach them afterwards, but I don't think it's necessary. We then need to measure where the inferior rectus is, diathermy, and we're going to recess it. I put a continuous suture in, remove the muscle, and you can see this oblique attachment, and we need to, when we're recessing the muscle, we need to maintain that oblique position. Otherwise, we're going to cause all sorts of torsion and various other things. We measure where it is, and we take a small bite through the sclera on both sides and end up with a fixed recession of the inferior rectus. Then using the same suture, we can go back behind the muscle and tie a bow here. So the muscle is fixed, but if we've overcorrected it, we can pull back the center of the muscle. Although this is during the operation, you can see how much we can pull back the center of the muscle. And I've improved up to 12 prism diopters of overcorrection using this technique. So it's a really useful technique. It's straightforward and easy to do, and I highly recommend it to you. And the last thing I was just going to mention is patients' expectations. Cure is not achievable. We won't get rid of double vision in all positions. We may need prisms afterwards, and you may need a second operation. And it's the same with the doctor's expectations. We mustn't be too disappointed if they need a second operation. So careful assessment before surgery. The muscles in thyroid eye disease are not and can never be normal, and improvement is possible. Cure isn't. Thank you very much.
Tony, that's great. Thank you. That was fabulous, and a great coverage of our topic. I think that you raise an issue at the very end that's really, really important, and that is patient expectation and impact on the patient, the psychiatric implications of this. This is a serious disease that really affects people. Also, I did want to point out to everybody that we're going to go over time. We got permission to go a little bit over, so we're going to be going over because our conversations have been so spectacular. I also wanted to talk about our Menti slides just for a moment. We've been asking questions of our audience, and I want to review those answers just really quickly. I'm going to pull up my phone where I see the answers. We have people from all over the world. More women than men are here. Our age range is the middle part of the bell curve is from 30 to 60. Most people are pediatric ophthalmologists, but we have oculoplastic surgeons and neuro-ophthalmologists. The test around the world that was most likely used to confirm the presence of optic neuropathy is the swinging flashlight test, about 50%. And then visual fields, OCT only 16%, with contrast sensitivity following that. And then we asked if racial norms are the best way to gauge the degree of proptosis, and 60% said no. And I know in our center, we look for the delta, the difference between where they started and where they end up. We asked if thyroid strabismus responds to botulinum, and people, about half said they thought it did. But that would change now after the talk. We asked if fat decompression makes strabismus surgery more challenging. Don and Jenny, 50% of people out there think that you make their strabismus surgery more challenging when you do their fat decompression.
David, I want to comment on that. I think there, among strabismus surgeons, I think there's this conception that the fat adherence syndrome is caused by touching the fat. So I think that is something that, if done properly and avoiding the area near the muscles, I think you can do safely fat decompression.
I agree.
Yeah,
Don.
I think a decompression, any sort of decompression, helps strabismus surgery by taking the muscles off stretch and giving them more room to move. Is teprotumumab available in your country? Not surprisingly, 85% of the people watching said no, 15 said yes. Who does strabismus surgery around the world? 65% said the pediatric ophthalmologist. 25% said the oculoplastic surgeon. We've got to fix that. And 15% said the general ophthalmologist. What type of suture do you use for thyroid disease? 40% say absorbable, mixed with sometimes using fixed. Some say absorbable with adjustable, and then a mix of every possible combination. So those are the answers to our initial questions to let you know what's going on out there around the world. All right, this is a free-for-all now in a discussion for a few minutes to talk about that. We just talked about strabismus and we've raised the idea of how decompression affects strabismus. I'd like to raise, how does teprotumumab affect strabismus surgery? Our strabismus team mentioned not doing resections after teprotumumab. Will we be able to do resections? Does that change how functional the inferior will be, Tony? Is it weaker? Does it change if we have to do a torsion? Are we going to see an entirely new approach to strabismus?
I think there's a strong chance that we will, because most of the strabismus is caused by inflammation in the muscles. If we can prevent that happening, which is why I asked, how early can we intervene with medical treatments? Because if we can prevent inflammation and damage to the muscles, then we're not going to get nearly so much strabismus. So, I welcome that. I think we should be aiming for that.
Mohammed, Saway, any thoughts?
I second it actually myself, but actually what I said before, I just want to repeat. So we want it to be available first and just affordable, and then we go from there. It is not easy. It costs a fortune in here, actually. And people will say they don't want to do anything. If you just tell them that this will cost a hell of a money, so nobody will accept it.
Yeah, and one question that's come in online that I want to share was whether or not vessel sparing surgery would be of value in these tight muscles that are already squeezing vessels. I know in reoperations for me of a thyroid, I do iris angiograms. Just wondering if anybody else worries about vessel sparing or blood flow to the eye.
No, is the answer.
I haven't had any, luckily, any anterior segment ischemia, but we could always stage the surgery, I suppose.
Yeah, absolutely. We can stage the surgery, and also it is helpful staging the surgery in thyroid eye disease, especially if they can just tolerate anesthesia.
So for our neuro-ophthalmologists, we reported that both Botox and strabismus surgery will lower intraocular pressure in thyroid disease. So if we're worried about the OCT or worried about optic neuropathy or elevated pressure, can we skip our oculoplastic colleagues and go right to strabismus surgery and cut them out altogether?
Yeah, I mean,
I'm teasing, obviously.
We just are preparing a manuscript about teprotumumab loading intraocular pressure in these patients, and I think that I can recollect maybe one or two patients that had really high intraocular pressures. I think the vast majority of patients have pressures in the 20s, and of course it can go up with against restrictive muscles and so forth. But I don't recall anyone actually getting glaucoma as a result of these sort of borderline pressures. I don't know what the experiences of the rest of the group is. I'll put them on IOP loading medications and so forth, but I don't know that glaucomatous optic neuropathy is the primary reason these people will lose vision.
For those of us that don't use Tepro or don't have access to it, what's the side effect profile like? Is it a horrible treatment or is it very straightforward?
For Tepro?
Yeah.
Is that the question? Yeah. No, we have had some patients that have had some side effects. We had one patient where the blood sugar went up in the 400 range. So that needs to be monitored very carefully. Cramping, I think, is very common. I've had a couple patients that one of my patients had pre-existing tinnitus, and he said, "Yeah, it's gotten a little bit worse." So I've seen that. And then I've had one patient said their hair was falling out, and I looked and I didn't see anything, but they said when they combed their hair, there was a little bit more in the sink. So it appears to be fairly well tolerated. I don't know. I'm interested to hear maybe what Jenny has to say and see if her experience is similar. Or...
I think similar. Most patients have tolerated well, but the sugar monitoring is a concern. So that's an issue that needs to be monitored. And patients sometimes will have an exacerbation of their inflammatory bowel disease. So that's contraindicated in those patients with that as well. But it is well tolerated. But, in other countries, like what you were saying, where that isn't available or the cost is too prohibitive, I mean, I think the other biologics and steroids are probably the way, and if we talk about this, is if this disease is inflammatory and it's going to create all of this fibrotic changes that are disfiguring and dysfunctional for the patient, how early do we treat? Going back to that question that David had asked, and because we had traditionally done this sort of wait and see approach to see if patients will burn out where they get to in terms of severity. But do we take a more proactive approach now to say, because we have more options besides just steroids and other monoclonal antibodies and such, do we take a more proactive approach for these patients?
Overall, I think that, go ahead, Dr. Granite. Sorry.
No, please go ahead and answer.
No, I was just answering Dr. Vivian's question about the Tepro. 37 people in our institute have received teprotumumab since February of 2020. And overall, the side effect profile has been very, very well tolerated. We have not had patients with blood sugars in the 400 range. That is a concern in people who have diabetes. But even in those, the maximum that I have seen is 135. It is a concern, but it's not a big concern. In terms of infusion reactions, about 4%, fatigue about 10 to 12%, hair loss 10 to 12%. And I think the only side effect that concerned me initially that I haven't seen a whole lot is this sort of sensory neural hearing loss, which we have not seen in our 37 patients so far.
The other thing I want to mention is in women of child rearing age, it's mandatory to have contraception because it's highly teratogenic.
I can't think of very many diseases in ophthalmology that cross boundaries this way. Essentially, we talk about neuro-ophthalmology, pediatric ophthalmology, and strabismus, oculoplastics, glaucoma or optic nerve changes that look like glaucoma. But we didn't talk about cornea and dry eye and the lids. Jenny and Don, could you just give us just a minute or two on what we have to worry about or how you deal with the exposure and the dry eye, as well as what the strabismus surgeon and what you do to deal with the lids at the very end so people look like themselves again?
Yeah, I think you're right, David. There are, I don't know of any other disease processes that affect the full breadth of our ophthalmic practice. And, I think thyroid eye disease can affect the lacrimal gland. So we're not only looking at a mechanical effect of lid closure, but we actually probably see some effect on the tear production. So it's really multifactorial. I think obviously we start with topical lubricants and artificial tears. And if that doesn't work, we can use short courses of steroids, topical steroids, but be cognizant of the side effects. And then I think you're right. The lid probably does need to be lowered in patients with severe lag ophthalmos or exposure. And then Botox, which you had a nice session on for muscles, can be used in the lid. So that can also be a temporizing measure. Jenny, you have any other thoughts?
The only thing I want to mention is in some of the patients, the curruncle is the only thing that's super enlarged from an inflammatory standpoint. And when they have that enlargement of the curruncle, it affects sort of their lid closure. And that's kind of a sign to look for in terms of just really severe disease or if they're going to get to a severe state. And so just paying attention to the curruncle as well and how to manage that during that whole process. But I agree with Don. I use Botox a lot for just giving patients sort of a sense what they would look like. Should we need to go into lid recession for the uppers, just so that they have a sense of what they would look like.
Sylvia, do you use Botox in the lid?
Yeah, of course. Sometimes you can help for the lid also. But one important thing, David, you said about talk all the time with the patients is the most important thing, because everybody knows that this type of patients are uncomfortable, are sad, are crying all the time. You can remember them. And this is because also at the same time of the changes in the orbit, is going to be changes in the brain, especially in the limbic system and also in the basal ganglia. So it's difficult for them to understand the disease because they have recurrences. They don't like even the effort we are doing. They don't like the response, but they are having these changes in the brain. So that's why we have to understand that they are not always complete, easy for them to understand the disease. And we have to follow up very close to them, time to time, helping all the time. And you can see that the problem is that even if you do the perfect surgery in the inferior rectus or whatever, they are going to change day by day. And sometimes we have patients that even having the biological treatment, whatever, they go back. So this is important to keep in mind that also the patients has a second problem in the brain. Maybe it's associated to the optical nerve problem. It's a good issue to study. So, David, it's this topic is very important to me, and you can see, as you said, all the specialists are together trying to do something else.
I think the benefit of having a team working with it helps those patients. And Don and I reported years ago that the psychiatric impact for depression and anxiety was on the same order of cancer and AIDS. This is a huge deal. They function differently. They look differently. Everything about their body feels different. It hits everything. And I'd add the endocrinologist. I'm going to ask everybody for one tip as we close, because we're now 10 minutes over. So we'll go around and ask everybody for their one fun pearl. Sylvia, you led me to my pearl, and that is, please don't forget about the patient and what they're going through, and remember to look through their eyes, not just through what we see. So that's my pearl. I'm going to take it as I see everybody across my screen. Mohammed, that means that you're going to be up first for one tip or pearl as we wrap up.
I just want to say that we should not forget that this is a teamwork. Actually, everybody should be just involved in this. Even the ophthalmologist and specialist ophthalmologist. So cornea, anterior segment, oculoplastics, and the strabismologist, in addition to the endocrinologist and neuro-ophthalmologist. And first of all, psychiatrist, as you mentioned, it is like a living cancer. So
yeah, I would add, you know what? I might add radiologists to that, so that we get good scans and they read them well. So it's all in. Everybody's in.
And radiologist. Sorry to just, I forgot the radiologist and the neuroradiologist and the radiotherapist, because we give them radiation therapy at times also.
Yep.
So it is a
Sylvia,
teamwork.
you're next on my screen. Yes, it is. Sylvia, you're next on my screen.
Okay, thank you. Just to remember to our fellows, to our friends, to keep in mind the use of botulinum, because this is a chronic and recurrent disease, and you can help with avoiding the surgeries if you can use the botulinum course of anything. And also, we don't discuss this, but I like the topical anesthesia. So this is 2 ideas to keep for you. Thank you. Thank you, David, and thank you, Jenny, and thank you, all of you.
Thank you, Sylvia. Salway, you're next on my screen.
Okay, so I would just like to remember that to tell the patient that this is a long road ahead. It's going to be a chronic disease.
Thank you so much for your input and for joining us again. You've been an unbelievable participant in many of these webinars. Thanks, Salway. Tony, you're next on my screen.
Can I have 2? Am I allowed 2 tips? Or is that greedy?
Oh, all right. We'll give the pushy Brit 2.
We've been talking about involving everybody, and I'd like to say try not to involve the vitreoretinal surgeon by using a grooved hook and not perforating the sclera. That was one small one. But my second one is really to join with Salway and say, I say to my patients, this is a journey, this is a train journey, and it has a number of stations on And I don't know how many stations they're going to be, and you don't either. But we're going to take the journey together, and we'll get there in the end.
Fabulous. Thank you, Tony. Jenny, thank you so much for co-moderating your Pearl.
Thank you, David. I would say that for the frontline eye care physicians, optometrists, ophthalmologists, to not dismiss the patient's symptoms that can lead to early diagnosis for these patients, so that to get proper treatment. Just because a lot of times, like Sylvia had mentioned, these patients are distraught and they have a lot of ocular surface symptoms, and a lot of times it can be dismissed. I just wanted to bring that in. Thanks.
Fabulous. We really are having a string of pearls here that are just magnificent. Rashmin, you have no pressure, but you have to keep up with these great pearls.
Yeah, thank you. First of all, I'd like to thank David and Jenny for moderating it so well. And thank you, David, Ken, and Ramesh for involving me here. I think my pearl was the way question was answered, that remember, dysthyroid optic neuropathy is not as malignant a disease like other optic neuropathies. It can be prevented or treated. And so clinical examination remains the gold standard.
Wonderful. And thank you so much for your input. Don, on my screen, you're next.
Okay, well, I would also like to thank you, David and Jenny and Ken, for inviting me, and this has been a fabulous symposium. I would always look at old photos. And the reason I bring this up, you and I have seen patients where they have proptosis readings of 15, and they have an MRD of +4, and patients will say, my eyes have come out and they are open more. And we look at their old photo and they were ptotic and they had deep set eyes. So they probably started with an MRD of 0 and they had exophthalmometry of 9. So always look at old photos, even if it looks like there is no obvious thyroid eye disease.
Thanks. A fabulous tip, and another reason why working together as a team matters. Madhura, you get to sum up and give us the last wonderful pearl, anything we left out, and this is it. You get to be the last word here.
Yeah, well, thank you so much. I think the organization of this seminar, the thyroid eye disease, could not be more timely. I will say, I have been in practice 15 years as a neuro-ophthalmologist and an adult strabismologist operating on these very complicated patients. And I can tell you, I have never felt more hopeful in my life as now. When I see a patient come into my clinic, I know I can offer them much more than just steroids and radiation. And just with the preliminary patients that we have seen respond to teprotumumab, my hope is that something similar, if not the agent, which is very cost effective, perhaps generic, can be made available to the rest of the world, because I think it will truly make a difference in interfering or disrupting the natural history of this disease. And that's really where my feelings are at this point.
Wow, that's a perfect sum up. I'm going to take 1 minute to do some housekeeping finalization and thank all of you, first off, for your participation. This has been spectacular. And I'll also let you know, it looks like we have gone over 4,000 people worldwide that were listening to you. This makes this one of the largest meetings in history talking about thyroid eye disease. I want to thank our sponsor, Horizon, and of course, NTOD, who has been our partner in all these webinars, bringing them to you around the world. They all appear on our YouTube channel if you want to see this later. And of course, I would be remiss if I didn't thank our WSPOS administration team, both Akila and Dara. They have been spectacular in making all this happen. If you want a participation certificate, just email program@wspos.org. Look at the spelling of program for those of you who come from different parts of the world so that you get it right. And that will give you a participation certificate. Here are our upcoming webinars. If you enjoyed this, it's only going to continue to be at this high level. March 27th, we have a virtual strabismus wet lab. Unbelievable. Teaching strabismus over the internet. And as you can see, allergic conjunctivitis is coming, retinoblastoma, another grand rounds. We have a session on nystagmus, inherited retinal diseases, malignancies in the pediatric eye, amblyopia and unmet needs, ocular pathology, updates in ophthalmology. We're going to have superstars in ophthalmology update us in pediatric ophthalmology about what's going on in the world, a second virtual strabismus wet lab, and then ROP. Please think about joining us at WSPOS. Membership is free. There aren't many organizations that can say that. You go to our website at wspos.org, join the Facebook page and group, and you'll have an ongoing discussion. Subscribe to the YouTube channel. The Pediatric Ophthalmology International Listserv has been going on now for 26 years. Email me. I helped moderate it and started it, and we'll get you on. In case I don't already know you, just give me your information about who you are, where you did your training, and if you where you did your fellowship, etc. And then again, thank you to all. This has been a spectacular meeting, and I can't thank you enough. With that, we'll end this here, even though we could probably go on for another hour. Only 20 minutes over. I think that's pretty good for this group. And again, thank you to all of you around the world. So with that, we say good night, good morning. Have a great rest of your day. Have a great sleep. And God bless all of you. Sylvia, thank God you're okay. And I hope everyone else in Mexico is as well. Bye all. Thank you again.
Thank you so much. Bye.
Thanks, David.
Thank you.
Thank you, David.
Thank
Thank
you.
you, David. Bye.
Bye.
Thank you all.
Bye.
Bye-bye.
Bye.